Okay, I got you, Krista. Thank you. So we've got other people on the webinar, but they're in Krista's office. So you guys may have that going on too in some of your offices. So let's go ahead and get started. The topic of today's conversation is around measurement-based care. And the thing we've been doing is talking about brief interventions and different techniques for therapy, for intervening with patients. We've spent the last 4, 5, 6 weeks really going through a number of things. And what I wanted to focus on, and the reason I saved this topic almost for the last, is the question is, how do we know what we're doing is working? If you implement something new, if you implement integrated care, if you implement collaborative care, if you start doing brief interventions, any of these things we've been talking about, the question is, did anyone get better? Did any patients get better? Because at the end of the day, that's actually what we're looking for. We're not, it's nice that we all feel good and we like what we're doing, but at the end of the day, did someone get better because we did EMDR? Did someone get better because we did behavioral activation and other things? So the movement really across the country right now is measuring outcomes in mental health. And a couple things that I'd be interested in, one, for you guys to put in the chat box. One is the beginning of this is actually screening. So we want to know what the first score is. What screening tools are you guys doing? And if anyone is measuring progress over time, please let me know. And then we're going to talk about some performance metrics that I'm betting all of you guys are up against. Those being percent of patients screened, depression screening and follow-up, and depression remission at 12 months. Those have all been added to community health center quality metrics. And some of the things that we're going to talk about today are going to be really helpful for that. Measurement-based care is not new. Here's an article from 1961 where a rating scale came out and everyone's going, wow, this is the future of behavioral health. It's been a few years since 1961. I will say I was born somewhere around that time, and I know how old I am. But going way back, measurement-based care isn't new. And if you think about the rest of medicine, if you have diabetes, it's your hemoglobin A1C. If you have hypertension, it's your blood pressure. If you have a broken leg, it's your x-ray. If you have heart problems, it's your EKG, and on and on and on. The rest of medicine uses integrated or measurement-based care. It's behavioral health that's been slow to the table on this, and we have certainly now reached the time when it's super important. I just threw up a case up here for you guys to sort of think about so you can see some of what we're going to talk about today. I've got a guy with a history of depression, and this particular person came in to see their PCP, which is what you guys are familiar with in your community health center FQHC settings because you're integrated. His primary care had started him on some medicine a couple months ago. He has a clear diagnosis of depression, and he was screened. We've got his original his PHQ-9, it's 22 when he came in, and now we've started some medication a couple months ago. And the kinds of questions that you as therapists would at this point be asking yourselves is, does he need treatment adjustment? And what should I do next? It's been 2 months. Would I repeat his measurement now? Is this the right timing? How would I know when to adjust care? What is my target for treatment response? PHQ-9 is 22. What's my target? What's my target for treating him over time? And the other kind of cool thing is, would you share the results with the patient? What does all this measurement do? Are they frustrated? Is it a helpful engagement tool? What does this look like? So here's just a case, and I've got some more complicated cases that we could go into, but I wanted to try something straightforward first so that you guys would just get a sense of what we're going to be talking about and what your process might look like. Now, why do measurement-based care? Well, the research over the years is really looking good. It's not perfect. You guys know that a PHQ-9 is not the same as a, it's not the same as a hemoglobin A1C, but we're getting pretty darn close. And what measurement-based care does, it can actually improve psychotherapy outcomes. Many of you are doing psychotherapy in your sites, but you may not be actually measuring care over time, or you're kind of automatically measuring it, but you're not doing anything with the outcomes. So what we have seen is it improves psychotherapy outcomes, and it improves psychiatric outcomes. I'm going to show you that in a minute. It really helps you treat to target, and we're going to talk about what some of those targets are. You can actually figure out who's actually getting worse. There's a really interesting study that shows sometimes we don't know that our patients are getting worse, that their mental health care is deteriorating. And that is sometimes, I think, pretty shocking to us. Their PHQ-9 might have gone up by 5 points. We didn't quite feel it. They didn't quite feel it. And yet, psychometrically, they're actually getting worse. And that is, there's, again, a study that shows this happens to us and we don't quite get it. We want them to feel better. We want them to have better satisfaction with care. Patients come in saying, gee, I want something that works. What are you going to give me? And it's like, okay, we're going to try something, see if it works for you, measure over time. And if it doesn't, again, we will look to see if we can find something else to do. As I mentioned, behavioral health is one of the last groups to actually be in the mainstream of medicine. This actually moves behavioral health. I have psychiatry up here. I actually talked to a bunch of psychiatry residents the other day about, hey, we're not in the mainstream of medicine. We are still the ones out who don't have a measurement tool. Now it's time we can actually move ourselves into the mainstream. And that probably has something to do with the quality metrics you guys are getting that you have to report on. This gives us an opportunity to do that and then be able to participate in new payment models. There's, what's it called? Primary care first, tailored plans. There's all kinds of stuff coming to you guys in your organizations in North Carolina, and getting paid that PMPM, getting a performance metric, or simply getting to keep the money you have because you're reaching that depression remission at 12 months or whatever that performance metric is. It really allows us to be able to participate in those processes. So there's a lot of great reasons to do it. Now, how about for you guys? How about for providers? What's in it for you? And I'll tell you, there's just sort of several things that we can think about. And the first is for you to basically know there's value in what you do. I don't know about some of you guys, but you get pretty burnt out in that day-to-day. We are safety net providers. We see some really tough folks. And it can really help you as a provider really know there's value in what you do. Even if the PHQ-9 or GAD-7 only moves 5 points, that actually shows you something's happening, that you're doing a really helpful service. It also, sometimes we just feel undervalued in healthcare. How many of us say behavioral health doesn't get paid enough? We're the stepchild to the Cancer Institute. We got the ugliest building. We're put in the back. Those are the kinds of things that can happen with us. So we feel undervalued. So this is a way to actually bring us value. Again, we don't want to make sure we're not missing out on any kinds of additional payment. That hopelessness and burnout, again, here's some perspective on it in terms of outcomes that can help. How many of you are stuck relying on productivity instead of standards? What if you were measured on % of your patients who had a good response on the PCL5 screen for a measurement tool for post-traumatic stress disorder, or the GAD-7 for anxiety, or the PHQ-9 or depression? So there's a lot of ways that this information can be helpful to you. So I just want you guys to think about, this isn't, it's not just for patients. It can also be quite helpful for you. And I'll be curious what you guys think as we move to the bottom. This is the study that changed my practice. This is actually a study of psychiatrists, a group of psychiatrists, right? We've been trained up one side and down the other, I don't know, 12 years of training to get to this point. And one would think, okay, well, we really can tell when someone's better or when they've hit remission. Well, give a psychiatrist a tool, people get better faster, they hit remission faster. It is just absolutely, to me, it was absolutely amazing. So their patient's time to response was faster. Their time to remission was faster. I mean, cut in half practically. And what they did was the psychiatrist made more rapid treatment adjustments. They're like, oh my gosh, it's been 6 weeks. Your score's still high. Let me double the Zoloft. Or, oh my gosh, it's been 8 weeks. I'm a little late here. Let me change your medicine because this isn't working. They made more treatment adjustments. They ended up with higher doses of medicine. And guess what? There was no difference in side effects. So plenty of patients need different kinds of treatment. Sometimes that's higher doses of medicine to bring down their scores. So after this study came out in 2015, I put a clipboard out on the chair outside of my office, and everyone filled out their metrics, their psychometrics, I like to call them, before I saw them. And this was like, I don't know, well, the study came out in 2015. So this is when I started doing it. And it really made for a nice way for me to look at it, and for me to talk to patients, which I thought was real cool. And then this paper came out in 2016, and this is the paper that has really started to change the field. And some of you, if you're in a management job, you may have already seen this paper. They may already be talking in the Office of Behavioral Health about this, but this is the paper in 2016 that began to really move the field, because this looked at the world's literature on measurement-based care. And they looked at it and they found what works and what doesn't, and what we need to be doing moving forward. Absolutely fabulous paper. I'm just gonna summarize it for you. What doesn't work? Well, one-time screening doesn't work. That annual screening, that screening once every 5 years, that screening because we thought about it today, it doesn't work because we're not following and tracking people over time. And actually that new performance, it's not so new performance metric, depression screening and follow-up, was actually trying to address the follow-up part, because people were just screening. Wow, we're all happy about our 78% screening rate, but no one got better. And no one got better because there was no follow-up. And in terms of effective follow-up, there was no measurement of symptoms. The symptoms were assessed too infrequently. If me as a psychiatrist, if I start a new medication today and I tell the patient to come back in 2 months, that's 8 weeks later, they need to really be assessed once a month for response. So now I've waited too long. Or if you guys have a patient, they get a diabetes check once every 3 to 6 months, and we're assessing them. Oh, well, we're going to give a PHQ-9 when they come in next time. They've started a new antidepressant. We'll check them next time when they come in. That's too long to wait. That's too long. We were assessing symptoms too infrequently. People are left to suffer, not do better. And sometimes they actually stop their medication because they don't like them. It's also not a good idea to send a PCP a whole list of patients and all their PHQ-9 scores, because the PCP goes, what the heck am I supposed to do with this? Because it's outside of the clinical context. So the PCP needs to see, and you as therapists, you need to see the psychometrics at the time of your appointment with the patient. Okay, you're seeing them today for a therapy appointment. The PCP seeing them tomorrow for to review their diabetes, or to actually review the fact that they put them on an antidepressant. Make sure that is available in your workflow at the time of the appointment, and don't ask the PCP to do it. And it's better even for you if someone has done these psychometrics before they get into your office, even, so that you don't have to sit there and use your time to do it. It's also, in my mind, it makes more sense for the patient to fill these out on their own. It's quiet, peaceful. They can use their own head and not have you asking them bluntly question after question. I just think they're more forthcoming if you just leave them alone and let them do it. So what is effective? What we know is defining the timing. That's what we mean by systematic. So PHQ-9, GAD-7, even PCL5, we want to get them at least once a month. If we're doing alcohol use disorder, the Audit C is a great tool, maybe every 2 weeks on that. You need to have a system in place for administering the tools. That system has to make sure it's frequent enough to capture change, as we mentioned before. And now we can adjust care without waiting. If that EMDR you're doing isn't working, if that interpersonal psychotherapy isn't working, if that Zoloft isn't working, we don't have to wait. We can go ahead and adjust care a whole lot sooner. Remember that graph, remember that study I just showed you? People got better faster, and in some cases, literally cut them a time to getting better in half. And that reduces suffering. It shows you the incredible work you can do, and it shows you the power of these tools and how just really amazing that I think they are. Here is the paper I mentioned earlier from the Meadows Institute that came out in 2021. In the back of it, they have all the tools. So we're gonna put this link in the chat box. If you download this paper, the whole back of it is full of the tools for you. So you don't have to go looking. This has been, after that 2016 paper came out, everyone jumped on it, began giving you all these tools. The Kennedy Forum has tools. These guys, the Meadows, updated it. So from 2015 to 2021, 6 years later, this is a really lovely update of that 2015 paper that you saw earlier. Again, all the tools are listed. And then the National Council for Behavioral Health, I'm guessing some of you are involved or members of that. They just came out with a paper. They like to call it measurement informed care. We don't necessarily, in their mind, we don't necessarily base our care, all of our care on this number from this psychometric, but we use it to inform our care. So Dr. Chung from New York, he really likes the idea of calling it informed care. But again, they list all the metrics. I was actually part of that advisory committee. So everything's listed for you. You don't have to go chasing this down. When we think about these metrics, we want them to be short. We want them to be client filled out if possible with kids. You know, it would be a parent. Not too time consuming for the patient, not too time consuming for you. We want them to be, they have to be reliable and valid. Don't go make up your own tool, because if it's not valid, it won't be accepted in terms of payers and performance metrics. So you really can't just pick something out of a hat. It needs to be, as I mentioned, brief. And a lot of these 3 to 5 minutes for a patient to fill out a PHQ-9. And you guys know, you just glance right down the right-hand side, you can score it in 30 seconds. So that is just fast. It needs to be diagnosis specific. The PHQ-9, if you have depression, is a good measurement tool. If you don't have depression, don't be given the PHQ-9. You need to give a tool that's diagnosis specific. You want it to be, if you can, free. There's a lot of open source, PHQ-9, GAD-7, PCL5. They're open source measurement tools, Audit C. You don't have to go ask permission to do it. Here's a list of some of the tools that you will find in those couple of papers I just showed you. I think every single one of you has seen the PHQ-9, the GAD-7. The PHQ-9 works for kids, GAD-7 works for 12 and above. There's a measurement tool called the SCARED, which is for kids between 5 and 11 before they can switch over to the GAD-7. A lot of you have PTSD that you're seeing in your clinics. The PCL5 actually comes from the VA, and this is the civilian version. Substance use is a little tricky. Sometimes functional status might be more helpful, but there is a tool called the BAM, the Brief Addiction Monitor. I'm going to show you in a minute, which definitely has these tools that can be used. And if anyone has any other measurement tools, validated measurement tools you're using, let me know. Please note the CAGE, the CRAFT, the, what's the other one? The mood disorder questionnaire. There's a lot of things that we use that are not validated measurement tools. So if you use them for screening, if they have the condition, you got to switch over to a measurement tool. It is best, I mean, this makes sense, and more time efficient if your screening tool is the same as your measurement tool. So just keep that in mind. And again, I can answer any questions about this as we get to the end. I am guessing there's not a soul on this call who hasn't seen the PHQ-9. Again, a score of 10 or above is where we start to get concerned. 5 to 9 can sometimes be watchful waiting, but less than 5 is remission. And this is that, that score, that performance metric, depression remission at 12 months. They're looking for a PHQ-9 less than 5. This is tricky. It's hard to get. Patients have a lot of comorbid conditions. The number tends to be around 20%. So don't kick yourself if you're at 11%, you're trying to improve. 20% is good. Okay, 20% remission for our safety net clinics is good. All right, so we just want to keep an mind on that. PHQ-9 is the question about suicide. If you want to push this out through a portal so that patients get it done the day before, something of that nature, I encourage you to do the PHQ-8, leave question 9 off, because if they say they're suicidal and you don't notice it, you don't have a trigger in the portal before they see you, before they get to you, then that causes a problem. The PHQ-8 is validated. It's a good tool that you can use. Just keep that in mind. This is what the brief addiction monitor looks like. A little bit longer than some of our scores, but that's okay because we need something to measure substance use. So the thing about this scale is you want consumption scores drop and protective factors increase. So on the BAM, patients will have 2 scores. You want one to be decreasing and one to be increasing. It's I really like it because I like the fact that you can measure the protective factors that are going on in the patient's life. And you can kind of see down here, physical health, trouble sleeping, depressed, how many drinks. As we start getting down here now to number 4, we're getting to consumption and we're looking to see what's happening with that. That's a really cool tool. Now, I'm guessing that some of you guys, this is part of what's going through your head right now. Here are these barriers to implementation. I'm not going to read them to you. It's a great chart out of this neuroscience paper from 2018. But number 1, people worry about time. And that's why an iPad in the waiting room, pushing things out through a patient portal, the MA, if you're in a primary care setting, or if you have a medical assistant, or even your receptionist handing this on a clipboard with paper like I used to do before the patient comes in, really helps with the timing. You shouldn't be sitting there asking these questions. We need to figure out how to get this completed. And we're doing this in my organization right now. We have the front desk is handing out laminated copies so we can take them back and then we can erase them. We can take all the markings off before the next person comes in. People are worried about all the patients don't like them. Well, it's all about talking to the patients about, just like other health conditions they have, measuring outcomes is super important. So training and measurement-based care, your staff need training. Don't just go throw a bunch of PHQ-9s out there and expect everything's going to work out just fine. They need to be trained on why are we doing this? Who's going to do it? What are we doing? When are we going to do it? How are we going to do it? The typical things that we think about around implementation science. So really working up to it and not saying we're going to start this next month. Let's work up to it. Let's meet with staff. Let's explain it. Because this list right here, this is the pushback you're going to get. Okay. These are some of the things those of you who are therapists on the call are probably already thinking. And we need to really get beyond or have some faith in the system when we're starting to do this and say, okay, these papers are coming out. The evidence is here. All right, it's not an A1C. Yes, I have to use clinical judgment. You can imagine someone would take their pen and answer all 3s on the PHQ-9 or all 0s on the PHQ-9 while they're crying in your office. We understand. For some patients, we're going to have to think about language barriers, all these things. But for the most part, and for the most people, this can be incredibly helpful. And then train them on patients when things are different. So that's when we talk about implementation science. For those of you who want to do this, is to really think, what are patients thinking? What are your clinicians thinking? And again, I said to a group audience, for those of you who were at the conference last week, we were talking about this, right? And I said, how do you guys right now, if you're not doing this, how do you know your patients are better? And someone in the audience said they laugh more. And I said, great. Explain to me how payers are not going to pay you for laughing more. We wish they would, but they will never pay you a performance bonus for laughing more. But you may get off the hook for depression remission at 12 months, depression screening and follow-up, because you're able to actually now present good numbers, good psychometrics to them. So these are kinds of the things. It was just funny. I always wait for that one. We used to have that. For those of you who have to do treatment plans, and it's 10, 15 years ago, they were almost to the point of ridiculous, because we didn't have, you had to have measurable goals, of course. And we didn't know what to do. And so we would literally say, we'll laugh 3 times during session. We would have something, because we had to pull something out of a hat. Now we actually have real validated information that we can use. So the barriers are making sure we have training and resources, that our administration is removing barriers, that our IT team knows we need to get this into data fields. We don't want this in narrative fields. You can't pull the data. We won't be able to pull it in a spreadsheet or a registry, or we want a way to pull this, which means there has to be a data field in your electronic health record where you put the information so it can be pulled. It's always great to have champions. We have 1 or 2 people, actually 4 or 5 people in our organization who are gung-ho. They've been doing this before we even started making everyone do it. They are great. They just walk around and they infect the rest of the staff now. We've given them a job, they're champions, to actually talk it up and encourage everyone else to do it. So it's really kind of fun to watch what a champion can do. All right. What do you do with all these numbers? Where do you put them? We've talked about why to do it. I've shown you the evidence base. We've talked about what these tools look like. I've given you sort of a list and a couple references. So you have go look by diagnosis. Remember, they're diagnosis specific, but go look by diagnosis, and got a nice list for adults and children and geriatrics and substance use that you can go through in those manuals that I've given you. And we've talked about, where you're going to end up, what's going to happen in your organization, what are those barriers, and what are some solutions. So we've sort of covered that, in the first 30 minutes or so of our time together today. Now we're going to talk a little bit about, how do you store that information? How does an individual staff member use it? How does a supervisor use it? And how does a whole clinic use it? Because when you begin on an individual patient basis talking about this, it is great. It's great for the patient, it's great for the therapist. That's wonderful in the exam room. But you can actually aggregate the data. Again, this is why your EHR has to have a distinct data field. You can begin to pull the data together and use it to say, this is what our psychotherapy department is doing. This is how well our PCPs are doing on their own. Here's how well our psychiatrists are doing. And then here's how well our clinic is doing. And that tends to be the HRSA performance metrics that you guys have to report are clinic-wide, right? You have your numerator and your denominator, and those are clinic-wide. So that's, again, aggregate data that your organization's already pulling together. And so a really cool way to do this is to develop a registry, because what you really want is first and last PHQ-9. Now, this depression remission at 12 months, there's some funky ways that information's getting pulled, and it doesn't really take into account first PHQ-9, last PHQ-9, some of those things, and what happened in between. It's just at one point, does this person with depression, are they in remission or not? So that's a little bit of a tricky one for an index episode of depression, which is what you guys are working with. So a registry is where you pull all the information together. What it helps you do is make sure no one falls through the cracks. If you have a patient who has depression and they sort of disappear, they become an issue for your performance metrics. And it's an issue because they're out there suffering somewhere. So if you have a list of all your patients, it actually shows you who to outreach to. And that could be your therapist outreaching because it's in their caseload, a peer support person, a community health worker. A registry helps you see, hey, it's been 3 months. The person no-showed for their last 2 appointments. I can see that in my registry. I need to give them a call. And again, now you're tracking these outcomes. So every single PHQ-9 goes in your EHR. And in your registry, you have something that looks like first and last PHQ-9. You can click on it, it graphs it, actually shows you where you are. It's way cool. And then if the person's not getting better, it prompts you, hey, what I'm doing is not working. The medication's not right. The psychotherapy approach isn't right. We aren't getting their social determinants of health taken care of. They're still homeless. So it prompts you to really do something different with their care. And that is one of the really main things that leads to the performance that we want. And then it really helps you, reach those targets, reach the targets that you want for the patient, for your organization, to help everyone feel like, what we're doing works. Hallelujah. It also helps you prioritize your patients. So when you go to your supervisor, you and the supervisor look over your registry and you say, hey, I've got 10 patients on my registry who are just kind of stuck. Their PHQ-9, their GAD-7, their PCO5, whatever it is, isn't getting better. And what it allows you to do when you guys are doing supervision with your supervisor is to really get their input on what could I be doing about these 10 patients? Or if you have a chance to meet with a psychiatrist, maybe that's part of your review. We always went and met with the therapist once a week, Wednesday mornings at 10. They would pop up and give us some patients that are stuck. And it's not just the most complicated, difficult patients, but it could be someone that's kind of in the middle who's still stuck. Their PHQ-9 started at 16, they're at a 14, and they've been there for a while. Compared to maybe the person that starts at 20 and now they're 22, and those people are really stuck. So we want to make sure we not only get the most difficult, but we also come a step down in that, our most difficult patients will take up most of our time because they really have serious problems going on. They're in a lot of distress, and we really want to figure out how to help them. They're more complicated. And there can be all kinds of issues why people are engaging in treatment or not. And we know how the social determinants affect that. So now you can go to your supervisor, and a supervisor can actually look and see, hey, here's some patients we need to talk about. This is what a registry might look like. This is one my organization developed years ago to kind of help us think about how patients are doing. And what you can see is the name of the person, the name of first time we saw the initial assessment. We can also look at most recent contact. That actually helps us see if it's been months and months, hey, this person's disappeared. We need to reach out to them. How many contacts we've had all together and the weeks in treatment. So what does that average look like? And then you can see here, first psychometric. This happens to be the PHQ-9. Over here is the GAD-7. This person came in really with a lot of problems. I mean, pretty intense symptoms, may have even been suicidal. Last contact, and this took about 8 months. This isn't easy treatment, 7 months maybe. Their last PHQ-9 score was 9. So they dropped from a 21 to a 9. And what we're looking for in your organization, and I really don't like this depression remission at 12 months performance metric. You're stuck with it, but I don't like it. What's much more useful is in the course of treatment, they had a 50% reduction in their psychometric score for most of them. Some of them, it's a little different. Adult ADHD, the bars, we want 30% drop. But for most of them, and this is what the FDA uses to approve your new antidepressant or your new anti-anxiety medications, they want to see at least a 50% reduction. So this person went from 21 to 9. They had a 57% reduction. We have we color coded this Excel spreadsheet so it turned green, so you know, hey, you've made it. This patient, the second patient, is actually getting worse. This is a really nice flag. They've been in treatment for almost 6 months. Things aren't getting better. This is someone we need to talk about, okay? This is what you would talk about with your supervisor or the psychiatrist. Or let's say this patient, they're just in psychotherapy and you've been trying to convince them to get on medication because you know they're not getting better. You're tracking and watching this. And maybe you can now use these numbers to say, hey, look, you're not getting better. And in fact, you seem to be doing a little worse. What do you think now about reconsidering an antidepressant? So you can use these numbers for all sorts of things. This patient down here with the 10, they hit a 4. Remember, depression remission is a PHQ-9 of less than 5. So this person actually goes into your hopper for depression remission at 12 months if they can maintain that remission number. So for this patient also, you can see now you're starting to meet these metrics. And because you have all this follow-up, you're also meeting depression screening and follow-up. So this is way cool in terms of how you meet those metrics. And it's about patients not suffering, right? We're getting them better. We're getting them better quicker. We're getting them better significantly. Look at these numbers. And we're going to go to our supervisor and talk to them if, in fact, the person's getting worse, not getting better like we want. It's really slow. We can really take a look now at what's going on and go get some help. Someone's not getting better. Ask a colleague, ask your supervisor, ask the psychiatrist. What can we do next to help this person get better? So that's how a registry helps you, helps the patient, number one, helps you as a therapist, number two, helps your supervisor, number three, help you, and helps your management team actually see how well is our clinic treating depression. And that depression remission at 12 months score, I'd love to hear what you guys are getting. I heard 1.2% for a clinic the other day. It's so low, it's discouraging. Now, all of a sudden, you watch those numbers begin to improve, and that's going to help you feel better. You should be proud of that when this begins to happen. And the only way you're going to get that depression remission at 12 months is to do measurement-based care. Now, you want to share the results. Upper left-hand corner, fabulous. This is rare to see in 8 weeks. This person got better on both they had anxious depression or they had anxiety and depression together. Hallelujah. This is a wonderful graph. Sometimes we see the graph on the bottom. And if you guys kind of think through this, they could have, let's see, they could be intermittently not taking their medication. You know, we see that all the time. They could have what? Chronic pain condition, right? When the pain's better, their score gets better. When the pain's worse, their score gets worse. They could have a personality disorder, and this is kind of tough to treat based on the emotional dysregulation they're experiencing. They could have a substance use problem. And here they kind of stopped drinking for a while, scores got better, but then, started drinking or using heroin or meth or whatever it is, alcohol, and their scores are just like a roller coaster. What this bottom scale says is, hey, we need to do something different. And we used to, I'm going to show you a slide in a minute. We used to put these graphs up on the wall on a computer screen and show them to the patient, point out, look, this is what's going on. I think really need to get you into DBT group. What do you think about going to the DBT skills class? I always call DBT a class because they're in there learning those 21 skills. What do you think about, because your scores aren't getting better. This is motivational interviewing. What do you think about these scores? We know that drinking's been a problem for you. What do you think about this? And the patient goes, wow, doc, they don't look so hot, do they? And I say, no, what do you think you want to do about that? And they say, well, maybe I should go back to AA or they're not sure. And then you begin that part of motivational interviewing where you begin educating. Okay. So motivational interviewing, when folks are in a situation like this, using it to kind of think through what we could do differently is super important, because there may be things they have not wanted to do. I'm only going to see you. I'm only going to do this. I'm not going to do anything else. I'm too busy at work. And you start showing them a graph that looks like the one on the bottom, and you and your supervisor see this and you're going, we need a plan. This can be an incredible tool for engaging patients. This is the screen we had up on my office at work. This is vital signs. So this is blood pressure, BMI, let's see, diastolic, epistolic, their temperature, their, what is that, respiration rate. They all showed up, their heart rate showed up in here together, okay? So you can kind of see up here, this person has some hypertension, and we're kind of watching it to see what their response to medication is. Right here, things seem to get better on this date. Wonder what they were doing here that really helped with that. The BMI is kind of fluctuating, heart rate's okay. It really helps you helps patients monitor their own process, on their progress. Patients with diabetes, sometimes they want to know their number. You know, what's my number, doc? If my number is 9 and I want it to be 7, we want it less than 7. I think in safety net clinics, it's less than 9. And that's actually a performance metric for you. You can say, look, you're at a 10, we need to get you below 9. And the patient goes, oh, okay. Now I've kind of hooked it onto a number. And so that can be extremely helpful. As I mentioned before, you can aggregate the data. Sometimes providers need data to report to their licensing boards. You know, this is how I'm doing for diabetes. This is how I'm doing for hypertension. This is how I'm doing for depression. And they have to do this, especially for Medicare, and that's MIPS and MACRA data that your PCPs have to be reporting on, and many of them are seeing the same patients you are. So what does that look like? You want your clinic to be doing a good job. Maybe this is a way to talk your administration into starting a DBT group or chronic pain group, because you're showing that rickety graph we saw earlier, and you really feel like that might be due to you know, really not having extra services, EMDR, DBT, whatever it is, MOUD treatment for opioid use disorder. You begin to think about, what is it we need to do? We just come in here and we're doing interpersonal psychotherapy with everybody, meds with the psychiatrist or the PCP if they need it. And if a clinic's just plugging along doing that, you're really missing an opportunity. Look at your data and let it help guide, what do we need to add or maybe subtract? If you're doing a service and no one's getting better, maybe we don't need to do that service anymore. Think about anything special you brought in. If patient's not getting better, stop doing it. You're wasting your time and the patient's time. And then, of course, informing reimbursement. And again, we're all in tailored plans now in North Carolina. There's going to be a PMPM payment for, you know, how sick your patient is, what tier they end up in. And if they have a behavioral health condition, some of those, like schizophrenia, bump them up to tier 3. I don't know if it's 3 or 1, which one's the worst. I can't remember. But that's, you're going to get paid based on that. So this really can help inform, you know, how you're doing, how the patient's doing. All right, let's go back to that patient who has a history of depression, PHQ-9 of 22, started on and I would say escitalopram. This is the starter dose, 10 milligrams, 8 weeks ago, 2 months ago. Remember, it takes 4 to 6 weeks to get the maximum benefit of an antidepressant. So let's take a look. What's your first consideration? That PHQ-9 of 22 was done 2 months ago. All right. So what would be your first step? Anybody out there? What you going to do? Remember, one of the core features of effective measurement-based care. What are we going to do next? Don't be shy. Just a small group of us. Krista, you got a whole room full over there. I'm sure someone's already yelled out the answer. What are you going to do first? Yeah. Rosalind, was that? Yeah, go ahead.
I was just saying a new screening should probably PH.
Rosalind, you're going on and off mute. I don't know what's going on with your computer, but I think I heard you right.
A new screener or current screener should be conducted?
Absolutely. We said once a month. Now, one thing about language I want you guys to think about, because you're going to be the experts when you go back to your teams. Screening is that first evaluation that you do, and then you use measurement tool. Okay, we're not going to rescreen them. We're now going to measure them. Okay, so just keep that in mind. Everyone says, and that says this is classic, Rosalind, not picking on you. A lot of people say, I'm going to repeat the screener. Just remember to say, I'm going to repeat the measurement tool, but you are spot on, because that 10 milligrams of escitalopram, this person may have a PHQ-9 of 9. They just, boom, drop their score 50% over this course of 2 months. And if it didn't, you repeat it now, because that really is the first thing. And because, you know, if the patient comes in and says, well, I feel a little bit better, the PCP usually goes, well, okay, here's a 6-month prescription now for 10 milligrams of escitalopram. If that PHQ-9 is still high, What I would say to the PCP, and hopefully what the PCP's got in their back pocket, is bump it up to 20 milligrams. If the patient got somewhat better, let's go ahead and bump it up to 20, wait a month, try again. Maybe this person, we want that 50% drop. Boom, we want this person to go at least to 11, if not lower. We'd love for them to be less than 5. I want you guys to think in your organization, even though depression remission at 12 months is what the standard you're being held to, I am more concerned about a 50% reduction because that is clinically meaningful to the patient. And even a 5-point reduction can show us there's a signal that they're starting to get better. So that would be kind of minimally effective. Maybe something's happening. 50% drop, absolutely. Remission's the holy grail. Okay, so we're going to keep going and going and going. And then the question here is, would you share these psychometrics with the patient? I absolutely would. Hey, you came in at your this patient health questionnaire. I'm noticing you scored a 22. Patient's already said go on an antidepressant. You're like, great. And the doc says, all right, we're going to measure your PHQ-9 over time. And they may also be in therapy. So if you guys are measuring this in therapy, then the PCP will use that same score. We don't want to be measuring in primary care and measuring in behavioral health and no one sees anything. That's why we got to make sure we put it in the data field. So that is how you use this, what we just talked about, to help this patient get better. If this patient had PTSD, we would do the PHQ-9 and the PCL5. If their PHQ-9 got better, but their PCL5 didn't, maybe this person needs to be in a DBT group. Maybe this person needs to learn some adapted DBT skills. Remember, we talked about in brief interventions, you don't have to have full-on DBT training. Maybe they need that written exposure therapy we talked about if you want to give that a try. So then you're still tracking those metrics. You've got to think about your workflow. Who's going to do this? Do not think the PCP is going to do it. This is not for the PCP to do. All of this should be done, even over here on this scribble. The medical assistant out on the receptionist out on an iPad, and that merges with the EMR in the clinic. Somewhere else, this needs to be happening in the workflow. It needs to be consistent, thought of. You can talk about it in huddle in the morning. Behavioral health people can say, hey, your patient's coming in for a primary care visit. Would you please grab a PHQ-9? I've been trying to get a hold of them. Or they're coming in and I need to record this depression remission 12 months score. Please grab it. It can happen in the huddle in the morning, a note to the MA, message people, put a clipboard on the chair outside your office. I don't care what you do. Figure out in your workflow, all of you guys together with sticky notes, put a big old piece of paper on the wall and figure out in your workflow, where are you going to do it? How often are you going to do it? Who's going to enter the data? Is it the provider? Is it a medical assistant? Is it somebody? Is it the receptionist? Who's going to give the repeat tool? Don't, every single detail, don't leave any details out. What are we going to do if people aren't getting better? I've talked about these metrics, screening, reduction, remission, but also think about functional capacity. A lot of people go, I got people that are homeless, their PHQ-9 is never going to drop. It's like, yeah, but did they get housed? Did they get a part-time job? What does this look like? What are maybe some functional tools? And then your organization, maybe looking at cost and utilization. What we can actually see is ED visits begin to change up. We begin to see some changes pretty quickly. And these are so important to your C-suite guys around around doing some of the metrics that they are being asked to do. So I'm going to stop sharing for a second. We've talked about quite a few things. And I want to see in the last 8 minutes that we have, if folks have just thoughts about this. You don't necessarily have to have a question, but thoughts about how this might work in your organization, or if you're already doing it, what's that experience been? Or if you're not doing it, just what are the barriers? What are your thoughts about it? Any thoughts, Amelia? I saw you turn on your video.
Yeah, specifically barriers around like giving the measurement tools or?
Yeah, implementation at all. I mean, are you guys doing this at each visit? Are you, how
Yeah,
are you guys?
I think that it goes in phases. Like I feel like I'm pretty good at doing screeners and then doing measurement tools because I'm interested, like especially with folks with a PTSD diagnosis. I really just try to work with them like this is not a lifelong diagnosis and we can, heal from this. So that's something that I just try to keep in my head and work on with my patients. But I'll just go through phases where it's on the forefront. I'll do the measurement tools really often, and then other times if I'm doing another piece of work, it'll just fall out of my head. But just within our electronic medical records, it's pretty easy to do them and check on them. So
Yeah, and so that's why, a couple things that you just said, Amelia. One would be, are you using the PCL5 tool to monitor? That's great. I see you and Tiffany both nodding. That's perfect. So that's a great tool. If they have post-traumatic stress disorder, sometimes people don't have PTSD, and using the PCL5, they're very diagnostic specific. But Amelia, that is why this needs to be an organization-wide specific. Everyone knows their role. The front desk, it is best if you don't have to do that tool. If that is ready to go, either the patient walks in with a piece of paper and all you have to do is enter it, or it is actually done and entered before they even get into your room. Front desk knows. They've got a little a notification on the chart, a tickler, and they've actually gotten it done in the waiting room before they even see you. So that is why it is so important for it to be organization-wide, systematic. The CEO requires it, has gotten everybody organized so that it won't fall off for you if there's a workflow where it's getting done that doesn't require you to remember it, right? If you had a registry that said, hey, Amelia, time to get that PCL5. So that's just an excellent example of you're a champion of this, you're trying to do it, but the workflow is making it harder. It's a barrier for you, and it's the job of your bosses, number one, to demand it, that this happen across your organization. This is what we're going to do. But number two, make it easy for you. You are busy. You have patients stacked up. I know how you work. And then you're just a great example.
I have a question about like effectiveness of measurement tools, because sometimes like we have a new check-in process and sometimes the questions will just be asked in that check-in process, which is electronic. And then I've heard nurses doing the PHQ and GAD, and then I know how I do them. Is there any, like, are they just the same? I feel like I hear really different answers from people if they're writing them down themselves or being asked by a nurse or being asked by a behavioral health provider.
Oh yeah, I mean, go through, do you wear a helmet? Do you wear a seatbelt? Are you feeling depressed? Are you feeling suicidal? Do you weigh yourself? Do you eat fruits and vegetables? Imagine if it's just a rote question, and then I'm talking to I don't know who this person is, and they ask the PHQ2 and I say no and no. So yeah, leave them alone. Let them fill it out on an iPad. Let them think about it. It takes 3 to 5 minutes for a patient to fill it out. How long does it take you to ask every single question? It takes possibly longer than that, because then you got to stop and discuss them all. The second thing to remember is it's a tool. It's not an A1C yet. It's a tool. If the patient puts all no's for the nurse and they're sobbing in your office, pull out a PHQ-9 and redo it. Thank you, Amelia. I really appreciate your input. Stephen, did you have a question? I see you came off.
Yeah, yes. So I really like the idea of the patient registries. We're in fact working on something similar to that I'll kind of come up with for our office. However, I like the example you displayed much better than what we're currently doing. I think that was better. What we've started is kind of a step in that direction, but what you displayed is more sorted out. And I'm like, I would kind of like to do that and maybe add the cage aid to it for our folks. But you were saying you were saying you don't have the counselors or providers actually keep track of that themselves. So who would you recommend do that? The front desk support staff, MAs?
You all need, every organization is different, so sit
Uh-huh.
down, a big old, you do a measurement-based care implementation team, put together a team. It's gonna need IT, management, you, a therapist, put together a team, a nurse, an MA, and put that piece of white paper on the wall. Start with your sticky notes, and you guys need to figure it out for your, some people may have iPads, some people don't, some may have portals, some people don't. But figure out who it might be. It might be, it has to be the therapist. That's not what we want, but that, if you can figure out another way, that is certainly better.
Yeah, that's going to be the challenge in our organization is just, I think it's a great idea, but I don't want to stick myself with having to do it because in our department, most of our people's Excel skills are rather limited. So we'd have to do like an Excel training first and then go from there.
Well, the goal is to just get it in your electronic health record and then let your IT people suck that information out with Tableau, or there's things I don't even understand what they are, but they can extract it. They are already extracting a lot of data for HRSA. They have to, or Medicaid. But let them figure it out. But you just have to get it in a data field first. That's the important piece. So that is IT stuff, Stephen. You don't have to put all this in spreadsheets and stuff. It's their job to give you a dashboard you can look at every morning when you open up and see your patient list. Okay, I want to remind people next week, we're gonna, it's evaluation time. We're also gonna talk about how to think about psychiatric resources in your organization. I'm guessing most of you don't have enough psychiatric time, don't have those resources. I just want to talk about getting creative. And Amelia and I don't know where'd she go? Oh, Amelia and her team work with me to get some additional psychiatric resources. We're going to talk about some examples of how to do that. And then we're going to save a little evaluation time and kind of those last questions. So get people to hop on. We will do that, and that'll be our last session next week. We also want to hear from you what else you need, and we'll try to get Justin on the call with us. All right, everybody. Take care. The slides are on slides, and the 2 links for those papers are available to you. And so let us know if you have questions next week. You can bring up any questions you had or thoughts you had after you had a chance to think about it, okay? All right. Take care, everybody. Bye-bye.